Well, good morning, everyone, and welcome to General Session 3. I'm Dr. Carrie Anders from the Duke Cancer Institute in Durham, North Carolina, and I'm joined by my co-moderator, Dr. William Sykoff, from the Women and Infants Hospital Breast Health Center in Providence, Rhode Island. This session focuses on novel endocrine and targeted therapies in advanced hormone receptor positive, HER2 negative breast cancer, including exploration of mechanisms of resistance and selection of treatment. At the end of each presentation, there will be 5 minutes of live Q&A or via chat, and Dr. Sykoff will introduce our first speaker.
Thank you, Dr. Anders. Our first presenter is Dr. Virginia Kaklamani of our host institution, the University of Texas Health Science Center at San Antonio, who will present GS301, Emerald, a phase 3 trial of elacestrant versus standard of care endocrine therapy in patients with ER-positive, HER2-negative metastatic breast cancer, updated results by duration of prior CDK4/6 inhibitor in the metastatic setting.
Dr. Anders, Dr. Sykoff, dear colleagues, on behalf of my co-investigators and patients of the Emerald trial, I would like to present these phase 3 clinical trial results. These are my disclosures. Endocrine therapy plus CDK4/6 inhibitor is standard of care first-line therapy for the management of ER-positive, HER2-negative metastatic breast cancer. However, tumors eventually develop endocrine resistance, mainly through the development of ESR1 mutations. Treatment guidelines recommend the exhaustion of sequential endocrine therapy prior to resorting to later-line chemotherapy or the emerging antibody-drug conjugates, which bring their own tolerability issues. While endocrine monotherapy is an option, this approach has shown limited efficacy in the second and third-line setting after prior use of CDK4/6 inhibitors, modestly extending median PFS, and intramuscular injections have poor bioavailability and are burdensome to our patients. Combination endocrine therapy has a higher rate of adverse events and a nearly 25% discontinuation rate, and limited efficacy data post-CDK4/6 inhibitors. Recently, we saw 2 studies evaluating CDK after CDK, returning mixed results. In this context, there is a significant need for a potent oral SERD for monotherapy use to enable also oral-to-oral combinations. Elacestrant is a next-generation oral SERD which has demonstrated a statistically significant improvement in PFS compared to single-agent endocrine therapy in the Emerald trial, including in patients with tumors that are ESR1 mutated. Here, we will examine the impact of duration of prior CDK4/6 inhibitors on PFS and share updated safety results. Multiple oral SERDs are currently being investigated as second-line therapy in HR-positive, HER2-negative advanced breast cancer. These trials have different inclusion criteria. Emerald is the only trial that mandated 100% prior use of CDK4/6 inhibitor and allowed for prior use of chemotherapy and fulvestrant. Earlier this year, we presented data showing that the use of chemotherapy decreased the rate of PFS. The Emerald trial also included patients with both primary and secondary endocrine resistance. Here's the schema for the Emerald trial. As a reminder, this is a phase 3 trial in patients with ER-positive, HER2-negative metastatic breast cancer. Patients were randomized to either elacestrant at 400 milligrams daily or investigators' choice of endocrine therapy, which was either fulvestrant or an AI based on prior endocrine therapy use. The 2 primary endpoints of the trial, PFS in all patients and PFS in patients with ESR1 mutations, were discussed last year at the Symposium by Dr. Bardia and found to be statistically significant in favor of elacestrant. The Emerald trial was designed to enroll patients with characteristics representative of the US patient population, including mandatory prior use of a CDK4/6 inhibitor, as well as allowing prior treatment with fulvestrant, chemotherapy, alpelisib, everolimus, and use of more than 1 CDK4/6 inhibitors in the metastatic setting. The trial also allowed the enrollment of patients whose tumors had primary and secondary endocrine resistance. As reported previously, both treatment arms were well balanced for demographics as well as patient characteristics. Over 2/3 of the patients had visceral metastases. All patients had a prior CDK4/6 inhibitor. Almost half the patients had 2 lines of endocrine therapy in the metastatic setting. Approximately 1/3 of the patients had prior fulvestrant, and approximately 1/5 of the patients were exposed to chemotherapy in the metastatic setting. The median duration of CDK4/6 inhibitors before randomization was approximately 17 months. Since the length of duration of CDK4/6 inhibitor is one of the parameters used to determine endocrine sensitivity, we conducted a post-hoc analysis of elacestrant versus standard of care based on the duration of prior CDK4/6 inhibitor in the metastatic setting. We divided the patients into having at least 6 months duration of CDK4/6 inhibitor, 12 months, and 18 months. These results show that the longer the duration of CDK4/6 inhibitor therapy, the greater the benefit from later lines of endocrine therapy, reflecting a more endocrine-sensitive tumor. The observation was more pronounced in the elacestrant arm. PFS rates at different pre-specified time points demonstrate a consistent benefit of elacestrant over standard of care, and as shown at the 18-month PFS rate, there was a nearly 5-fold increase in PFS rate for elacestrant over standard of care. As shown on these Kaplan-Meier curves, the longer the duration of prior CDK4/6 inhibitor therapy, the longer the median PFS on elacestrant versus standard of care. The benefit of elacestrant over standard of care is even more pronounced in patients with tumors harboring an ESR1 mutation. 71.6% of the patients had prior exposure to a CDK4/6 inhibitor for at least 12 months, and 50% for at least 18 months. Patients who had at least 12 months of prior CDK4/6 inhibitor therapy achieved a median PFS of 8.6 months with elacestrant compared to 2.1 months with standard of care endocrine therapy. PFS rates at pre-specified landmark time points also demonstrated a consistent benefit of elacestrant over standard of care. As shown on this slide, there were no patients with ESR1 mutated tumors on the standard of care arm who were progression-free at 18 months. But as you can see, 30% of patients on elacestrant were progression-free at this time point. Patients with ESR1 mutated tumors who had at least 18 months of prior CDK4/6 inhibitor exposure achieved a median PFS of 8.6 months with elacestrant and 2.1 months with standard of care endocrine therapy. In order to further characterize endocrine sensitivity and the benefit of elacestrant, we looked at the intervals of less than 6 months, 6 to 12 months, 12 to 18 months, and over 18 months. We continue to see benefit of elacestrant in patients after 12-month duration of prior CDK4/6 inhibitor. The 6 to 12-month interval seems to be a transition period where ESR1 resistance starts to build. It is important to note that we also have benefit of elacestrant in the less than 6-month group. Of course, the patient numbers are small in this analysis, but it gives us a further feeling of the patient population and the dynamics of endocrine sensitivity. Updated safety data were consistent with previously reported results. Most adverse events, including nausea, were grade 1 and 2, and there were no grade 4 treatment-related AEs reported. Only 3.4% of patients receiving elacestrant and 0.9% receiving standard of care discontinued therapy due to treatment-related AEs. There were no deaths reported as treatment-related in any of the arms, no hematologic safety signal, as well as no patients in either arm having sinus bradycardia. Antiemetic use was low, with 8% of patients receiving elacestrant and 10% of patients on an aromatase inhibitor receiving an antiemetic either as prophylaxis or treatment. In conclusion, EMERALD is the only pivotal phase 3 trial of an oral SERD with 100% prior CDK4/6 inhibitor usage. Longer duration of prior CDK4/6 inhibitor therapy in the metastatic setting is associated with longer PFS on elacestrant versus standard of care. Patients whose tumor harbored an ESR1 mutation who had at least 12 months of prior CDK4/6 inhibitor achieved a median PFS of 8.6 months with elacestrant versus 2 months with standard of care. No new safety signals were identified. No patient had sinus bradycardia, and antiemetic use was low in both treatment arms. These updated results demonstrate that monotherapy uses of elacestrant is safe and significantly prolongs median PFS versus standard of care and meaningfully extends landmark PFS rates. Elacestrant can become an important oral endocrine monotherapy in the second and third line treatment as an alternative to combination therapies that are associated with challenging safety profiles. I would like to thank the investigators, the 478 patients and their families and caregivers that participated in this study, and also Radius and Menarini for their support.
Yeah. Thank you very much, Dr. Kaklamani, for your presentation. We will now take questions from the audience, but I will take the prerogative to ask one myself. Since the advantage of elacestrant over fulvestrant appears to be largely, if not wholly, limited to cancers that documented an ESR1 mutation, if the results of EMERALD lead to the FDA approving this agent, do you think there should be a companion diagnostic?
So that's a great question, and I guess I'll leave that to the FDA to decide. But you are correct. The majority of the benefit of elacestrant is in the tumors that have ESR1 mutations. In the main PFS analysis, the hazard ratio in the non-mutated tumors was less than 1. It was 0.86. So there is potentially still a small benefit, but most of that benefit is in the ESR1 mutated tumors. I think the fact that we do genomic testing as part of finding PIK3CA mutations, that ESR1 mutations status will be important.
Thank you very much. Microphone 5.
Vogel, New York. Thank you very much, Virginia. I probably missed it. How did you measure ESR1 mutations? Was it on circulating tumor DNA or on primary tumors or on recent biopsies of metastases? And in what percentage of the patients on the study was ESR1 determined?
It was on circulating tumor DNA, and the majority of patients had ESR1 status determined. Actually, I take it back. You could either had a mutation or it was a no mutation detected, which could potentially have included some patients that had a mutation and that wasn't captured in that ctDNA.
Thank you.
Microphone 3.
So Jin Tan from University of Mississippi. Thank you, Virginia, for the next update. Have you looked at the distribution of ESR1 mutation among those 3 groups? Because the longer they are on CDK4/6 inhibitor, the less chance they'll have a mutation for ESR1.
So we haven't looked at that. I think that's a wonderful point. This was a post hoc analysis, and we're still evaluating all of the molecular data that comes from EMERALD, and that will be included in future presentations.
Okay.
Thank you.
We have 3 questions online, and all of them deal with the subset of patients who had prior fulvestrant and whether similar benefits were seen in those patients as those who were switched to fulvestrant when they were enrolled on the study.
Those are great questions as well, and that result has been presented, and the answer is yes. And we saw that with the phase 1 clinical trial as well. The patients on fulvestrant still received the benefit from elacestrant.
Microphone number 4.
Robertson, Nottingham Derby. Can you tell us, did the ESR1 mutations relate to the prior AI therapy? And if so, what percentage?
I don't have that data yet.
Okay, I think we have time for one more. Microphone number 5.
Lubna Chaudhry from Medical College of Wisconsin. I'm thinking a little bit ahead with this question, but given the efficacy, if this does get approved, how do you feel we would incorporate this in PIK3CA positive patients with us using alpelisib with Faslodex?
And I urge you to hear Dr. Andre's talk after mine and a few others, because I'm sure he's going to put it all together. But this is my humble opinion. I think we need to recognize which patients' tumors are endocrine resistant and which aren't. If you look at the outcomes, not just in this trial, but others, of patients whose CDK4/6 duration is less than 6 months, it gives you the idea that these are resistant tumors that we probably need to move on to either chemotherapy or potentially combination endocrine therapy. But those treatments are toxic for our patients. And so in patients, and there's a large number of patients that are on a CDK4/6 inhibitor for more than 12 months, more than 18 months, I think those patients, we need to make a decision after their tumors progress on a CDK4/6. Should we give combination endocrine therapy, even if they have a PIK3CA mutation, or should we give monotherapy? And hopefully we'll have options for those patients.
Thank you again, Dr. Kaklamani.
Thank you.